Hey everyone, it's Nurse Mike here from SimpleNursing.com. Today we're breaking down diabetes mellitus, or what I like to call diabetes, type 1 and type 2, and all the must-know NCLEX key points. So stick with me. I'm going to be sharing memory tricks to make this info really easy to lock in. And for my Simple Nursing members, be sure to grab these two study guides to follow along. You'll walk away feeling confident and ready to ace this exam. All right, ready to crush it? Let's get going.
Since this blood is turned to mud from that thick sugar, and over time this high sugar destroys the vital organs and blood vessels, leading to kidney failure, nerve damage, blindness, and even high blood pressure. Now to clarify, DM is for diabetes mellitus, not for direct message. So guys, it doesn't go down in the DM. And it's not the same as diabetes insipidus. Guys, DI is a diuresing peeing problem, not a sugar problem. Now for pathobasics, as you know, blood sugar naturally increases when we eat. The pancreas releases insulin from the beta cells, and also enzymes to help break down food for fuel. So remember, insulin puts sugar and potassium into the cell, making our hungry cells really happy. Now when we give insulin, both sugar and potassium decrease in the blood, since it's going into the cell. Now if we don't have food, then the pancreas has a backup plan. It releases glucagon hormone to break down stored glucose, aka glycogen, in the liver, which increases sugar in the blood. Glycogen is kind of like a glucose brick wall. So remember, glucagon means glucose gone out of the liver into the bloodstream, which increases blood sugar. So again, when blood sugar is high, like after you eat, insulin is released. And when blood sugar is low, like when you exercise or forget to eat, glucagon is released. So in diabetes, insulin is the problem here, guys. Type 1, we have none. Since the body has killed its own pancreas, it produces no insulin. And people are born with it. It's an autoimmune disease. So type 1, you can pass on to your son, since it's genetical. And these patients are insulin dependent for life. Big key word. Now in type 2, remember, few insulin receptors work, since the problem is you, your diet and lifestyle. The high in sugars and sitting sedentary lifestyle. We're talking junk food like sodas, white breads, and sweets, which eventually leads to obesity. And our cells now are lazy and overused. The insulin receptor sites are like an overused keyhole. They've basically been worn out, and now just ignore the insulin. This is called insulin resistance. So just think, in type 2, the cells are through. They quit responding. Now the risk factors for developing diabetes. Guys, in type 1, there are none, since it's mostly genetical. You can pass it on to your son. And in type 2, the problem is you, your diet, and a little bit of genetics. So we screen for metabolic syndrome, which increases the risk of not only diabetes, but also heart disease and stroke. Now this is big on exams in the NCLEX. So we use the acronym BOL for metabolic syndrome. So guys, 3 or more criteria means we have metabolic syndrome. So B for blood pressure meds and high BP, over 130 systolic. Our next B is for blood sugar medications or high blood sugar over, key word here guys, write this down, 100 fasting, over 100 fasting. O is for obesity, big key words here guys, waist size over 35 for females and over 45 for males. And lastly, L is for lipids that are high. This is not good. We're talking high cholesterol panel. Write these numbers down, 200, 150, and 100. All should be low except the HDLs, our happy lipids. That one should be over 40. Now guys, if these numbers are off, it could mean metabolic syndrome. And this contributes to insulin resistance in type 2, where the cells are through. Again, like an overused lock. The cells stop responding from the overuse of insulin. Now I can already see questions coming up on your exam and NCLEX. So I recommend writing this BOL memory trick out at least 15 times the week of your exam. Now to help you, here's a common practice question. Which clients are most at risk for developing metabolic syndrome? A 35-year-old male with triglycerides of 140. Nope, guys, the triglycerides are under 150, so that's okay. How about option number 2? 48-year-old female with a fasting blood glucose of 105. Guys, yes, fasting sugars over 100, metabolic syndrome. Option 3, 55-year-old female with a waist size of 40 inches. Oh yes, over 35 waist. And a 28-year-old male with a blood pressure of 135/85. Guys, yes, the systolic pressure is over 30. Lastly, a 42-year-old female with high HDLs of 55. Guys, no, those are the only lipids that should be high. Over 140. Just think the high lipids for HDL.
If you want to master questions just like these, our Simple Nursing membership has exit prep lectures and thousands of practice questions, all crafted by current professors and NCLEX writers.
Now, speaking of type 2, technically not a cause, but a very particular sign of insulin resistance. Keyword, write this down: brownish or dark thickening on the neck and armpits, or even hyperpigmentation and skin tags. This is what's called acanthosis nigricans. Now, as far as diagnosing diabetes, the top 3 must-know labs for the NCLEX that you will get tested on, guys. Write these down. Number 1, normal glucose must be 70 to 115. Number 2, fasting glucose less than 100. And third, hemoglobin A1C must be less than 6.5. Those are big NCLEX key numbers there. Write those down. Now, as you know, the A1C test is our long 2 to 3 month sugar audit, and it's best used to see if patients are being compliant with controlling their blood sugars the long term. So remember, below 6 is controlled and fixed, and over 6.5, we gotta revise. So review diet and exercise compliance for our type 2 problem, basically the U problem. And with type 1, insulin compliance, always on the NCLEX. Now, the most deadly is low sugar, under 70, called hypoglycemia, since it causes brain death. So we say hypogly, the brain will die. Now, all the other numbers on this chart just help diagnose the severity of diabetes, but are not highly tested on the NCLEX. And speaking of something that's not highly tested, a little side note here. The GTT, or glucose tolerance test, is when we give an 8-ounce drink of syrupy glucose to see if insulin is doing its job by putting the sugar into the cell. If it's not, then the sugar will go high. But guys, that's not usually tested on the NCLEX directly. Now, signs and symptoms and causes of high sugar or hyperglycemia. Just think, the blood is turned to mud. So the body tries to get rid of all this thick syrup with the 3 P's. First P for polyuria, a lot of urine. Basically, the body tries to urinate it out. Now, polydipsia is a lot of drinking fluid. The body tries to dilute all that sugar. Now, third is polyphagia, which is excess hunger as cells starve, since insulin's not doing its job to get sugar inside the cells. Now, a little side note, this is not polyphasia, which is a psych disorder. Now, the causes of acute high sugar can be caused from the 4 S's. The number 1 key term on the NCLEX is sepsis or infection, guys. That's a number 1 cause. But also stress from surgery or hospital stay, and even skipping insulin doses. And a big one here is steroids, those zone-ending drugs like prednisone. That is a big cause. But high sugar can also be caused from hormone therapy like estrogen. Now, we treat that high sugar with insulin to put that sugar into the cells. So for your test, I know this is going to come up. Yes, we increase the insulin during stress like sepsis, surgery, and especially with steroids. And guys, know the patient's not on insulin forever. Once the S's stop, then the insulin stops. And guys, big key word here, if the sugar is still high after the insulin, that's a critical situation. Always call the doctor or HCP. Now, on the other side, for hypoglycemia, that low sugar below 70, guys, just think low brain function, which leads to rapid brain death. So remember, hypogly, the brain will die. We're going to be watching for critical signs, the cool, pale, sweaty, or clammy. We need to give that patient some sugary candy. Now, typical NCLEX keywords include high wash. So headache, irritability, weakness or anxiety, and even shakiness and hunger. It's kind of like a Snickers commercial. You're just not you when you're hungry. Now, since hypo is so deadly that hypogly, the brain will die, our very first treatment is giving sugar. So on the NCLEX, if the patient is awake, then we ask them to eat. Specifically juice, soda, crackers, and low-fat milk. Not high milk or peanut butter. Big key word right there. The fat actually slows down the sugar absorption. And if they're asleep, big key word here is not alert or unarousable or only arousable to painful stimuli. Then we S, stab them with dextrose IV. And always reassess sugars every 15 minutes after giving insulin. Now, causes of hypoglycemia. They usually come from exercise, alcohol, and even insulin peak times. Big NCLEX tip right there. So watch out for diabetic athletes who exercise. If your patients exercise, then give extra glucose. Keywords: bicyclists, swimmers, and even runners. Now, alcohol is also a big no-no, technically with any disease, but it actually lowers sugar, doesn't increase it. And insulin peak times is when patients are most at risk for that low sugar. So remember, if there's a peak time, then we give a plate of food. Since hypogly, the brain will die. Now, 3 common test questions for that low or high sugar. Here we go. Test question number 1. A client with type 1 diabetes is only responsive to painful stimuli. With a blood sugar of 42, what's the first action taken by the nurse? Guys, this is the worst case scenario here. Anything less than 70 is bad. So hypogly, the brain will die. Now, patient is not alert, only responsive to painful stimuli. So if they're not awake, we can't ask them to eat. Technically, the patient's asleep, so we stab them with dextrose IV, and then we reassess blood sugar in 15 minutes. Oh, and if you chose option 4, I'm shaking my head at you. Question number 2, which medication could cause hyperglycemia? Now guys, before you even look at the options, you should already be saying steroids increase the sugar ending in zone, like prednisone. So guys, zone-ending steroids. Steroids increase the sugar. Now the tricky question number 3. The non-diabetic client is admitted for a kidney infection that has now turned septic. The blood sugars have increased from 150 to 225. What is the best answer to give a family member who's asking why insulin is used? So option number 1, the client now has type 2 diabetes. No, that's a wrong answer. Option 2, insulin is given to control hypoglycemia. Totally wrong. It's for hyperglycemia. Option 3, high sugar is common during infection and stress to the body. And insulin will help lower the sugar until the infection resolves. Guys, yes, option 3 is the best option. Super high sugars, we want to land like a plane, slow and steady. We don't want to crash into that hypoglycemia, that low sugar with low brain function. Now, if you chose option number 4, you nasty. Now, we get many complications from this long-term high sugar, where the blood is turned to mud. It's like dumping thick syrup into your blood vessels. And guys, imagine years and years of this. This destroys and scars the blood vessels called atherosclerosis or atherosclerosis, and leads to more infections since bacteria love sugar. Ultimately, it destroys all the organs. So the kidneys are washing machines that wash the blood. Guys, these guys die, which is called nephropathy or renal failure, indicated by creatinine over 1.3. So remember, NCLEX keyword, creatinine over 1.3 means injured kidney, and also means no more PP. So patients either get a transplant or go on dialysis to wash the blood. And nerves die, called neuropathy, so patients get loss of sensation. And they don't even realize when they get small cuts and injuries on their hands and feet. Not to mention the sugary blood. So we call diabetic feet delicious treats for bacteria. This leads to infections and slow wound healing, and then to amputation and cutting off of those dead feet from all the infections. Now, in the eyes, the small blood vessels break, called retinopathy, which leads to blindness. So NCLEX key term here, guys, frequent eye exams are recommended. And in the heart, we get hypertension from all that high tension on the heart, eventually leading to heart disease and then ultimately heart attacks. Lastly, in the brain, we can have CVAs or strokes from all those narrow blood vessels that either burst from aneurysms or get clots. Now, as far as diabetic treatments, guys, we're going to cover all the diabetic pharmacology, including the 7 rules of insulin. So write these down. These are the most tested. So remember, type 1, we have none or no insulin. The body destroyed the pancreas, so they are insulin dependent for life. And type 2, the problem is you, your diet, and a little bit of genetics. So remember, type 2, we have few insulin receptors working. So the first treatment is to fix you, your habits. So we focus on diet and exercise to help repair those broken receptors, aka increase insulin sensitivity. Then we give drugs like oral meds and insulin, but only if diet and exercise don't manage it alone. So for our 7 insulin rules, peaks equals plates, guys. Typically, we give food during a peak, since the greatest risk for low sugar is during those insulin peaks. Guys, the #1 way to kill your patient is not giving food during the peaks. So know your peak times. During peaks, we monitor for that low sugar below 70. Now, #2, if you get low sugar below 70, or if your patient looks shaky or trembly, the classic signs, pale, cool, sweaty, or even clammy, give that patient some sugary candy. The priority key terms, again, are the A's and the S's. If your patient is awake, ask them to eat. Always sugary food here, guys. So soda, juices, crackers, and low-fat milk. Not high-fat milk or peanut butter. Guys, fat will slow the sugar absorption here. And if they're sleeping, then we stab them with IV-D50. Sleeping means unresponsive or unarousable. Responsive only to painful stimuli. So don't just go stabbing sleeping diabetics here, guys. Always assess the sugar and symptoms first. And after you give sugar, always reassess 15 minutes later. We always follow up after any intervention. Always checking the sugar and the symptoms. Now the 3rd rule, insulin with no peaks and no mixes. It's our long-acting dudes. Guys, the memory trick is the old dudes, like grumpy old men who have been here for a long time. They're past their peak and they never mix well with others. They're basically antisocial. So the keywords, draw up in 2 separate syringes. So remember, Detromir lasts all year, and Glargine is large lasting. And Lantus is like a lantern. It burns all night. Now #4 here, guys, a big NCLEX favorite. They're going to try and trick you. So the IV-only insulin is regular insulin. So remember our memory trick here. Regular insulin is ready to go IV, or regular is right in the vein. Not NPH, not Lispro, not Lantus. Guys, no one except regular. He's the VIP for the IV. Now, #5, we draw up insulin. Always clear to cloudy. Guys, just think you want clear days before you want cloudy ones. So draw up regular insulin first, the clear, and then NPH, the cloudy, second. 6, we rotate locations every 2 or 3 weeks. And the best location is always on the abdomen. Keywords here, near the umbilicus, navel, or belly button. And guys, we never aspirate. Basically, never draw back on that plunger. It'll cause scar tissue and swelling. And also, we never massage or add heat after sub-Q injections. Now lastly, #7, DKA, the extreme high sugar condition in type 1 diabetes, guys. We have a separate video for that, but here's the big NCLEX question here. Do we give insulin on sick days? What if the patient's not eating or basically too nauseous to eat? Well, yes, we give insulin without food. We just monitor that glucose closely. So remember, we always increase the insulin during the S's, like stress, like surgery, sepsis or infection, and even sickness and steroids.
For everything you need to know to pass the NCLEX, make sure to check out our NCLEX Review lecture series and live cram sessions.
Now, as far as insulin types, who put sugar and potassium into the cells. Now, these are must-knows for the NCLEX, specifically the peak times, coming up 60% of the time in all endocrine questions. And a little FYI for the NCLEX. Guys, we're not using brand names anymore, only generic. So no more Novolog or Novolin. If your school is still using this, then they're behind on the times. So again, for reinforcement, our first group is the long-acting guys. Our antisocial old dudes. Guys, they have no peak and never mix with others. Big NCLEX keyword again. Draw up in separate syringes, never mix. These guys have no peaks, so they require no plates. Or basically, they're not food dependent. And hence, they have a minimal risk for that hypo low sugar. So the brain is pretty safe here. Again, our memory trick here is Detromir lasts all year. It's long lasting. And Glargine is large lasting. Now, NPH, our cloudy dude, always being mixed. So remember the N's. Intermediate insulin, and we never give it IV drip or bag. Guys, never put anything cloudy in an IV bag. Now, when we do mix it, always mix clear to cloudy. Clear days before cloudy. So we usually give NPH 2 times per day, not 4 times a day. So don't let the NCLEX trick you. Now the peak time is between 4 and 12 hours, but most dangerous in the middle, around 5 to 6 hours. So make sure you have a plate of food with that peak. Next is regular insulin that's ready to go IV. Guys, again, he's the only dude allowed IV push or IV bag. If you haven't wrote that down, please write it down. His peak is between 2 and 4 hours, so monitor closely for signs of low sugar. That shaky, pale, cool, and clammy, we need to give some sugary candy. Now finally, our most deadly insulins. They're the #1 priority since they have the #1 fastest peak and onset. 15-minute onset, guys, with a 30 to 90-minute peak. So rapid-acting insulin, remember, Lispro, Aspart, and glulisine. So memory tricks here. For Aspart, you got to remember to move your ass parts, guys. It's really fast. And Lispro, just think Lespro. Less time for the onset. It's 15 minutes. And glulisine, it goes fast like a limousine. It's super fast. So we give these during meals. Keyword here, patient is eating or there's food at the bedside. Again, guys, patient must be eating in 10 to 15 minutes, not before the food's delivered. Usually an NCLEX question. Those peak times are the must-knows for the NCLEX. So I'd recommend printing this study guide out and reviewing it every day the week of your exam. Now, a little insulin quiz. We're covering the top 3 most tested NCLEX questions on peak times. Here we go. Again, peaks are priorities. The fastest way to kill your patient is not giving a plate of food with the peaks. So remember, peaks require plates. So we drew a little plate on the flag showing the peak time. Now, our red rapid guides are the most deadly. Always monitor for hypoglycemia, that low sugar below 70. You're going to see shaky, sweaty, pale, and clammy, so we give that patient some sweet juice, soda, or candy. Okay, question number 1. The nurse gives regular insulin at 12 p.m. for lunch, but the patient doesn't finish their food. So when's the greatest risk for that hypoglycemia? Guys, the risk for regular, look at the peaks right here, 2 to 4 hours. So if given at 12, the answer is between 2 p.m. and 4 p.m. Never before and not after. So guys, memorize these peak times. Now question number 2. A client is on Aspart insulin. When should the nurse advise him to eat? Again, guys, this is an onset of 15 minutes with a peak time between 30 to 90 minutes. So Aspart, get your Asparts moving. The best answer is the soonest, so eating within 10 or 15 minutes. Now question number 3. The client on glargine is asking the nurse when is the best time to eat during this insulin? Well, guys, glargine is large lasting, long acting, no peaks. So no peaks require no plates. Pretty tricky one there. Now for a little bonus question. We saw this a few times in our NCLEX review. So the client taking insulin NPH with dinner at 7 p.m. What time is the client most at risk for that hypo low sugar? So NPH has a 4 to 12 hour peak. The most at risk, guys, we're looking at the green peak here. 5.5 to 6 hours has the most peak. So the best answer here is midnight or shortly after. Now before we move on to the insulin infusion pump, guys, the best way to memorize these insulin peak times is to print off the study guide or cheat sheet we provide, and guys, write this out at least 7 to 15 times the week of your exam. Now for insulin pumps, or CSII, the continuous subcutaneous insulin infusion. Guys, the #1 benefit is the steady dose of insulin for our type 1 kids who forget to take their insulin and are basically non-compliant. The biggest benefit and the coolest part here is we have fewer swings in blood sugar level. So not high and not low anymore, guys. It's a nice even basal rate. That's a big key word, even basal rate. Now, how do you manage it? Well, we usually check the blood sugar 4 times per day, and you push, keyword there, push an insulin bolus button at meal times to get that sugar into the cell. Now, what if you get an NCLEX question about a machine malfunctioning, guys? What do you do? Do you assess the patient or do you assess the machine first? Well, we always assess the patient first and then machine second. Now, that's really big on the NCLEX. Now, for oral agents, these are only for type 2 since the body responds to few insulin. Guys, the pancreas isn't dead here. It's just overworked. So oral agents help to decrease blood glucose and make the body more sensitive to insulin, kind of like repairing a broken lock. So we only use these after exercise and diet fail to manage type 2 diabetes. Big keywords there. After diet and exercise have failed. Now, in general, we never take oral meds with iron, calcium, and even antacids that contain calcium. These guys block absorption in the stomach. So guys, be careful. They're always in over-the-counter pills and medications. NCLEX keyword here, OTC, or over-the-counter. Now for our 4 oral anti-diabetic drugs, guys, write these down. Metformin, or brand name Glucophage, glipizide, pioglitazone, brand name Actos, and acarbose. Again, guys, NCLEX will not have brand names, only generic. But just in case, your nursing exams might still have those brand names. Now, the 2 biggest things to write down. We avoid alcohol and liver disease patients, since these drugs can be toxic to the liver. Now, first on the list is metformin from the class of biguanides. So guys, think big guys, like you met 4 men in metformin. They reduce the output of glucose by the liver and also increase insulin sensitivity. Now, that's not usually on the NCLEX, but the M's of metformin are. So remember this, minimal chance of hypoglycemia, that low sugar, major liver and kidney toxic. And lastly, we always hold 48 hours before cath lab, since contrast kills the kidneys and leads to lactic acidosis. So guys, hold metformin with cath lab.
Okay, now hold your horses here. A little NCLEX tip and side note. When metformin is not taken, the patient is switched to a sliding scale for insulin, but only temporarily. Now, this is typically done before and after a CT scan, or anything with contrast dye. Also during pregnancy, and if the client is NPO for something like surgery. So we say this because it's commonly tested, so I'd be sure to write that down.
And a little side note about the kidneys. Creatinine over 1.3 usually means an injured kidney. And urine output 30 mLs per hour or less usually means the kidneys are in distress. Next is sulfonylurea class. These guys stimulate the pancreas to release insulin. And they end in "ide" like glipizide or glyburide. And they're very bad for the heart. So think "ide," the heart may die. Guys, it's very bad for heart failure and MI history. Big keywords there. Now, caution, guys. The NCLEX and your exams are going to try and trick you with the suffix. Guys, other ide-ending drugs like furosemide, a diuretic, the body is dried. Or isosobride is a vasodilator. So our memory trick is the G's are for glucose, so glipizide and glyburide. And the F's, like furosemide, are for fluids that are dried. And the O's for isosobride are the O's for vasodilator. Now, just like metformin, they also have a mini chance of low sugar or hypoglycemic events. And they also cause massive weight gain. So again, guys, clients will not lose weight, they're actually going to gain it. And lastly, they also may cause sunburn, so we use sunscreen and protective clothing. Oh, and they're also toxic for our elderly patients. So metformin is always our first choice. Next is pioglitazone hydrochloride, which reduces insulin resistance, ending in "-one like thiazolidine dione. So think the "-one" or the "one" as one dead heart. It's very heart and liver toxic and a huge risk for heart failure. So again, heart failure means heavy fluid retention. Keywords here, new pitting edema, worsening crackles in the lungs, and rapid weight gain, which usually means water gain. Now, last and definitely least, since this guy's not really common on the NCLEX, alpha-glucosidase inhibitors, ending in "-ose like acarbose and precose. Guys, they rhyme with gross, since they cause massive flatus or farts and diarrhea. These guys are carb blockers. They break down carbs and decrease glucose. Basically digest food for you. But not given to IBS, irritable bowel syndrome patients. Now, as far as patient education for diabetes, we use the 2 Ds. D for diet, that's low in sugar and low in simple carbs. And D for diabetic feet, which we call delicious treats for bacteria. So the top NCLEX tips for diet. Keyword here is the lows. Low calories and low simple sugars. We avoid simple sugars with no fiber, guys. So soda, candy, white bread, white rice, and even juices. The goal is we want well-balanced meals with enough protein and fats, High fiber carbs, guys, these are good. So good carbs are the high fiber complex carbs. Typically, keywords are brown or whole. So brown beans, brown rice, brown bread, guys, not white bread and not white rice. Bring it down to Brown Town. Now the next keyword, whole, so the whole grains, the whole wheat, and even whole milk. All these include high fat, and even peanut butter has high fat. This helps slow the sugar absorption. Now these are called our low glycemic index foods. So just think fiber slows the digestion of sugar. But caution here, guys, the number one offender are fruit juices, which are usually very sugary, since they took out the pulp, which had the fiber in the fruit. Now second, we avoid those bad carbs with low fiber. That hits the bloodstream super quick, aka high glycemic or simple carbs. And you already know these carbs, it's the ones we love to eat. Typically anything white or sweet. So white bread, white rice, white pastas, even French fries, and deep fried anything, guys. And even low-fat milk. And also here, big keyword, fruit juices. And you already know the typical junk food. Candies, sodas, chips, and donuts. You know, all the normal nursing student stuff.
Oh, wait, what? This? Oh, come on, man! This is all I can afford after my tuition. I mean, I could be helping a tree make, you never know.
So we teach clients to avoid these bad carbs during normal everyday life. But guys, during low sugar crisis, like the sugar's less than 70, that's when it's okay. Now for your third test tip, what if you get a blood sugar of 60 or less in the AM? Guys, we always tell patients to eat a bedtime snack. And guys, the fourth thing is therapeutic communication. Guys, these are always the weirdest questions on the NCLEX. So they'll give you a totally awkward situation, then they'll ask, how should you, the nurse, respond? And guys, to be honest, there's only two options here. Either we ask more questions like, how do you feel, or how does that make you feel? Or you just be supportive. Guys, never ask why. Never use words that judge, accuse, or put the patient down. So guys, use common sense. Don't be a jerk or an idiot. Don't be an idiot! Now, we don't want patients to feel bad, so not victimized, not dependent, not helpless, or sacrificed. So guys, yes, be supportive and educate that patient. So yes, capable, yes, independent, and yes, in control and managed. Those are the goals. And lastly, number 5, fasting for religious reasons. The patient is going on vacation and plans to fast or plans to drink alcohol. Guys, the number one thing we do as a nurse is always assess the patient, not the family or machines. So we always assess first. We ask, we analyze, and we evaluate. Then we intervene. Keywords for that are give, administer, implement, educate, refer, or even advise. Now, in this case, what's going to kill the patient? Well, what's going to kill them is the low sugar below 70. Remember, hypoglycemia, the brain will die. So assess compliance, guys. We're assessing labs, med compliance, even history of blood sugar episodes like high and low sugars, and even extreme episodes like those DKA and HHS. So we always assess first and intervene second by teaching. Guys, in this case, we're teaching the patient to avoid dying from that low sugar. By always recognizing the shaky, cool, and clammy, we're giving the patient some soda, juice, low-fat milk, or some sugary candy. We're going to try to avoid that low sugar, below 70, to avoid that low brain from dying. Now, as far as diabetic feet, just think delicious feast for bacteria. Guys, bacteria will feast on all that sugar. So open sores will lead to infection, which eventually leads to amputation. Therefore, foot protection is huge. Guys, we have to love those toes. So the goal is CDI. NCLEX keywords, clean, dry, and injury-free. Not harsh, not rough, or damaging. Be gentle, be soft, be loving. So use our acronym FOOT for things to avoid. F for flip-flops, high heels, and nylon. Guys, no sandals, no bare feet, no high heels, so you're not getting fancy, and definitely no nylon. But yes for soft cotton, clean, and absorbent socks. Clean and dry is the goal. So big keywords to know for the NCLEX. Closed-toed shoes, comfortable, supportive, well-fitting, and sturdy. Oh, and also leather shoes. Guys, we have to love those feet and protect those feet. Now, avoid O for over-the-counter corn removal. Now, usually for the NCLEX, anything over-the-counter is usually always a big no-no for the NCLEX. typically the wrong answer. Next O is for overly hot, baths and pads. So no hot pads and no hot baths. Guys, patients have dead nerves and can't feel how hot the water actually is. So key words here. Always use a thermometer to test the temperature, never a hand. Thermometer, guys, testing the temperature. Since again, the loss of sensation in the hands and feet from that neuropathy, those dead nerves. And lastly, T is for toe injuries, probably the biggest one here. So listen up. Daily inspection, never weekly, always daily. And immediately report any injury to the HCP, or basically the doctor. Now remember, diabetic feet are delicious treats for bacteria. Open sores get infected very quickly, leading to amputation. And another big one here is the toenails. Big key words. Cut straight and file the edges. And I can already see this coming up as a question. Never cut at angles, always cut straight. And in the hospital, only doctors can cut those nails, never nurses. Now after shower, always dry between the toes using soft cotton towels. Guys, clean, dry, and soft. NCLEX key word here, separate the toes to dry. And yes, oil on the feet is okay. Now again, the big no-no list. No callus removal, no heavy powder, but light is okay. And no rubbing the feet hard or vigorously. Love those feet and be gentle, clean, and dry. Now you will get a select all that apply question about feet. So to help you practice, let's do this question. Which statement by the patient with diabetes, big key word there, indicates correct understanding? So option number 1, I will get comfortable fitting sandals. No guys, no sandals. How about 2, I will test the bath water with my fingers before getting in. No, we always use a thermometer. I will get routine pedicures for my callus, but not rub vigorously. Guys, no, never callus removal. How about option number 4? I will use leather shoes with cotton socks. Awesome, 2 big key words. Leather shoes, cotton. I will assess feet weekly. No. Always daily. And the last one. I will cut my own nails at angles, but file the edges. No, guys, we always cut straight across, but yes, we do file the edges.
Thanks for watching. Did you know you can unlock beautifully handcrafted study guides, packed with key points and memory tricks from all our videos? Plus, you'll get access to over 1,200 exclusive videos not on YouTube, all neatly organized by nursing school topic, to make that complex nursing knowledge actually stick. You'll also gain thousands of practice questions written by current professors and actual NCLEX writers. So for access to all this and more, click right up here or visit simplenursing.com. And don't forget to subscribe to our YouTube channel. Happy studying, and we'll see you in the next videos.